everyone, welcome to Fitness Actually. My name is Shu-Mei and I'm qualified physiotherapist here in Melbourne, Victoria. Today we're going to talk about what is occupational therapy and how they can help our seniors today. Today we have Bree Edwards, who is a well-qualified occupational therapist that I've worked with across Victoria and in Melbourne as well. Welcome, Bree.
Thanks, Shu-Mei.
So tell us a little bit about yourself. What is your background? What do you do and your interests?
No worries. So I graduated uni about 8 years ago. I went to Charleston and Albury, and I've worked across a whole heap of different settings. So I've done some public and private hospital work. I've done some subcontracting. I've worked for a private practice clinic. And currently I'm working at two of the major hospitals in Melbourne. My interests
Done everything.
Quite varied. Yeah, I've done a bit of everything. My interests sort of lie more around palliative care and oncology. I believe the dietitian was it last week, and spoke a bit about that from their perspective as well. So with that, I have done my lymphedema training, so I'm a lymphedema therapist as well. That's a bit about me. Yeah.
Beautiful. Okay, well done. Can you just tell us, for anyone out there who's never heard of occupational therapy, what it is, what you can do, and what you can help them with, especially for seniors 60 and above, 65 and above?
Yep. Well, we're basket weavers. No. So an occupational therapist, so what we do is we provide assessment and intervention to develop, recover, and or maintain meaningful activities to someone, and we would consider those occupations. So that's things like how people go every day. So with like their showering and their dressing, cooking, cleaning, getting out and about in the community, and also looking at their home environment to make sure that it's set up for them. So that's sort of what we do in a bit of a nutshell. Yeah,
okay, beautiful. So apart from like occupation, you also maybe we can talk a little bit about how maybe occupational therapists can help with disability, patients with disabilities. So like after they've had a stroke or they have a Parkinson's disease, they have, motor neuron disease. So how can you help them either both in an acute hospital setting and then later when they're home?
Yeah, so I guess in an acute hospital setting, so if that is a new diagnosis, so the need's just been identified, so we go through that assessment and intervention, as I mentioned before, to see how someone was going, I guess, before their diagnosis, how they're normally managing at home. And then we look at including strategies and intervention to get them back to being where they want to be at. So if someone wants to, say, be, I guess, independent with their meal preparation, we can work with them to come up with some strategies and things to make it a bit easier for them to manage at home. And that might be with some assistance devices, it might be with some equipment, just different strategies to include.
Okay, so what kind of equipment strategies, can you give an example?
Yeah, so for instance, I'm just coming back to that example of meal preparation. If someone is, example also with Parkinson's, so people can get quite fatigued, and that can really limit their ability to engage in their tasks, such as meal prep. So we might provide them with something like a kitchen stool so that they can sit down and prepare their meals. We might also give them equipment such as like a jar opener, food preparation boards. There's some new devices out, they've been going around for a couple of years now, that they've got a tremor stabilization. So some people with Parkinson's and other disabilities can be quite shaky in their hands and in their upper limbs. So there are spoons and forks and I guess general cutlery that aims to stabilize that tremor so that they can feed themselves independently.
Oh yeah, I think I've seen one of those before where like they're tremoring, but the spoon doesn't move much, and they can just put it in their mouth.
As well.
That's amazing. It must cost a fortune though. How much do you think those would cost?
Well, you can actually get one from a local supplier, and it's about $300, I think. And you need to charge them because obviously they're electric. But you can actually alternate the spoon head with a fork head as well. So yeah. There's one that actually twists as well, so you can twirl your pasta. It's amazing the things they have these days, yeah.
Well, hopefully, like in Australia, hopefully when they have the NDIS package or their
Yeah.
home care package, they can pay for it. They don't have to
Yeah.
like
Yeah,
out of pocket.
definitely.
Awesome. So
Yeah.
so let's say because you were talking about showering and dressing as well. Like,
Yeah.
how can you help with in that aspect?
Yeah. So with showering and dressing, so dressing as we get older, obviously our muscles may not be used as much. We might not be as active. So some people find it really difficult, say reaching down to put their socks and shoes on, or difficulty putting their
Yeah.
pants on. As we get older, balance can become a bit of an issue as well. So with dressing,
Yeah.
just providing some strategies, say sitting down to put on your lower body clothing before standing to pull them up. There are some devices. You can get a device called a sock aid. Sorry, I thought I had one here with me. Such as a sock aid, and that helps you put your socks on independently, and it just avoids that bending down, which you either may not be able to do, or if you've got back pain, it can just make that a bit easier. And you can get things like shoe horns as well, which helps your foot slide into the shoe properly. Yeah, so with showering, if balance is an issue, or there's just a fear of falling, or someone has a history of falls, you can get rails and things installed into the shower just to provide a sturdy support. And equipment like a shower chair or a shower stool might be beneficial as well. So that way the person can sit down and feel really safe when they are showering, and then they can stand up with the rail if they feel like it.
That's really good because I have a lot of patients like in the hospital or even a community where they come in and they tell me they haven't showered for years because they can't get into the shower and they can't stand long enough to shower. So they've been doing bird baths for years. And then when I tell them, OTs exist and they can help you with this. And they're just like mind blown. I wish that people knew that earlier. And the amount of patients that come in because they've fallen, just putting their pants on. And the worst part is picking up the tissue from the floor. That was enough to make them fall and break a hip. And then all you come in with is like, hey, here's a pickup stick. And it just changes your life. Oh man, I wish people knew better.
Yeah, and they're so multi-purpose as well. So pick up sticks, like picking things up off the floor to avoid that bending, but you can also use that to help put your pants on as well. So in turn that minimizes bending as well. So it's, they're really handy devices.
Amazing.
Yeah.
That's good. Amazing. So in going back to disability like management at home especially, how about like wheelchairs or any other equipment? Can you tell me more about that?
Yeah, so we do look at seating as well. So we might prescribe, say, a power wheelchair, a manual wheelchair, an armchair or a recliner. So depending on what the client's needs are. So I've done quite a few power wheelchairs and manual wheelchairs have been scripted. So if someone has a disability where they're sort of leaning to one side, or their pelvis is rotated, or they've got some sort of deformity, what we can do is we can actually do an evaluation and provide some measurements and provide a thorough assessment, I guess, of their body and their body positions to make sure that we're setting them up with a piece of equipment or a wheelchair that's going to be appropriate for them. So that can include many different supports. So if someone can't maintain a good sitting balance, they might need a tilt in space wheelchair, and that will enable them to obviously sit out and socialise and engage with others without that risk of sliding out of the chair. And then you can adapt the chair to suit the person as well. So we've identified the need that, yes, they're slipping out of a normal chair, but why are they doing that? And it might be that they don't have enough range through their hip to maintain that nice L shape when sitting down. So they're sort of sliding off. But then it's something as simple as even just reclining the backrest just to enable them to be comfortable might stabilize them enough, or they might need the full tilt function. So there are many different things, and it can address many different needs as well. So you can get scripted wheelchairs, power ones in particular, that the person might control with their right hand, and then if they develop some tremors or they're not safe or they're unable to use their hands, you might get something with the head control to enable them to still be independent and get around their home or to access their community.
That sounds like a lot of work and a lot of money.
A lot of work, a lot
I
of
think
money, and a lot of fun as well.
yeah. But at the end of the day, it's just money well spent that you'll use for the rest of your life to get a better quality of life. Isn't that right, Bree?
Yeah, definitely, definitely. And I
Yeah.
think
Rather than
with
being like,
disability, sorry, you
sorry,
go.
you go.
And I think with disability as well, so you've got the NDIS, which is for people up to the age of 65.
Yep.
And then for those that are over 65, you've got the home care package. So those are both government funded options that you can look at to pursue something like this. So it might even be worth just looking into having that initial assessment, even if it's just a one-off, just to identify any needs that might make you safer or more independent at home.
Yeah.
And yeah, because I guess a lot of people continue in their ways and they come up with different strategies that work for them. But sometimes people are doing things that are quite risky, and then that leads to them having increased falls or even just that fear of falling. And then you get into that cycle where you've got a fear of falling, so you're apprehensive, and then you have a fall, and then it just sort of continues from there, and you need to sort of break that cycle.
Yeah, I
Yeah.
agree. So let's say someone set up with a wheelchair, has all this equipment, but then just like most houses in Australia, they have steps and stairs. How do you
Yep.
overcome that?
For someone with a wheelchair, do you mean?
Yeah, but even like if they can't just get up, period.
Yeah, so
Both.
if someone's, okay, we'll start from the get-go. So if someone's able to walk and they're, say, holding onto the brickwork trying to get up, we can install rails at an appropriate height for the person so that they've got something secure to hold on to as they're going up the steps. The next
Right.
sort of scenario with people that are a bit older and their mobility may be reduced is they might have a walking frame. So with the four-wheel walkers or even the three-wheel walkers, it can be quite difficult on normal or standard steps, I guess we'd call them, with small steps to actually fit the
Yeah.
walker on there. So it makes it quite difficult going up and down. So we can add step extensions or build platform steps so that someone can actually put their walker onto the step, put their brakes on, step in the gap, and then keep going. If someone is, I guess, in a wheelchair or can't manage a platform step, then we might look towards a ramp. And that's where we might, if it's not a great height in terms of the step height, we might just sketch something up and send it through to a builder or handyman to complete. But if it is quite a major one and there's a complex environment or uneven terrain, we might get a builder out for a site visit and go through that with them to make sure that the client's happy and that it's going to meet the standards of practice and building codes, those sorts of things.
Amazing. Yeah, awesome. So how long would that take, roughly?
From start to finish?
Yeah.
Yeah. So I guess for an occupational therapy assessment for that, our initial assessments probably take around an hour. We will do some work off-site as well, which it depends on the complexity of it really, but it might take us half an hour to an hour to draw it up and send it through to the appropriate people. In terms of installation, it's really dependent on the provider and whoever's installing it. So some companies might take a couple of days to put it in, some might take a week and a half, 2 weeks. But then it also does come back to the funding because they can be quite expensive depending on what you're getting as well and what materials it's made out of. So if it's concrete, it is going to be more expensive. But if someone's, say, on a home care package, they might actually have reduced funds. So they need those funds to accumulate. So we might go out and make our recommendations and provide a quote. And then they might just wait for their funds to build up. And then once that's paid for it, the turnaround is quite quick. But usually the funding's the barrier. We can also do what's called a SWEP application. So SWEP is the statewide equipment program, and it is government funding for things like ramps, rails, equipment, anything that will help someone to, I guess, maintain their independence, increase their safety and remain at home. So the statewide equipment program's only really available to people that aren't on NDIS. Usually that are over 65, and typically if they're on a home care package, they need to have minimal funds. Level 3 and level 4 packages usually don't qualify for any further funding. through SWEPs purely because they already have government funding.
The maximum, yeah.
Yeah, yeah.
Amazing. Okay,
Yeah.
awesome. I think we covered a lot of it on that. And so
so.
when I first started working, I used to think that OTs pretty much did that only, and then I realized there's a whole heaps of stuff that they could do, such as cognition. So can you tell us a little bit more on how OTs can help with anyone suffering from dementia, Alzheimer's, Parkinson's that has issues with cognition?
Yeah, so if someone has cognitive issues, I guess we sort of work backwards. So if there's already a diagnosis, I guess for us, it's around understanding the diagnosis and then I guess gauging the person's, I guess their 24-hour pattern. So what things do they get agitated by? What calms them down? What things are they familiar with as well? So, and usually someone with dementia or Alzheimer's, often they are part of the older population. So with that will often come mobility issues as well. So it's about, I guess, having the environment set up to suit that person. Signage can be a wonderful thing as well. So if a person is looking for the toilet but they can't recall their environment, sometimes having a sign that clearly says toilet or bathroom or bedroom can be really helpful. We are often involved in that pre-assessment as well. So we don't diagnose, but what we might do if someone was coming to hospital or even working out in the community, if we identify that there is a bit of a deficit, we might just get that client's consent and do a cognitive assessment with them just to determine, I guess, what sort of deficits they have. So whether that's around their orientation, whether it's more complex processing, just finding that deficit and coming up with that score from the assessment. And then we might provide that to the GP and say, hey, can you have a look at this? These are the results that we got. Mrs. Smith almost set fire to her kitchen the other day because she forgot to turn the stove off, or she left the pot on the stove and it boiled down and caught fire. So can you just have a look at this and maybe do a bit of a review just to see where things are at? Because often with aging, you do have those slight changes with your cognition, but often not to the point where you're bringing harm to yourself or to others. So I think it's really important to get that diagnosis if there is deficit, and that way we can come up with some strategies to support people at home and link them in with the appropriate places.
Get the support early. Well, when it's mild, and then when it progresses, you're pretty much well supported. I actually realized after working with you for a long time, Bree, that you have a patient in the hospital that they're really out of it. They don't know what is what, where is what, and then you're like, oh, we'll just take them on a home visit. Bring them home, and they know exactly what to do. They have their routine. They wake up at a certain time. They take their meds at a certain time. Go to the toilet at a certain time, and then they just work beautifully. So well done on you, because I would have not known that.
It happens. It happens. So you get someone back into their home that they grew up in, and they know where everything is. Their mobility might have changed, but they know where they keep their stuff. So it's really important when you do get those clients with dementia, if they always keep their keys in a certain spot, or if they always keep their cutlery in the top drawer. It's really important that you do leave it in those positions so that they know where to find things.
Yeah, routine is the key, isn't it, Bree?
Yeah, definitely.
So let's say someone, you've determined that someone's cognition is really bad. You're not sure how they're coping. You've done the referral to the GP. And then after that, apart from doing, one-on-one, how do they get from the GP to you?
Yeah, so often we would refer to the GP, or if you're going the other way, if the GP's identified the issue, they might send a referral through to us, or they might send a referral. There's memory clinics as well. So the GP will often send a referral to a memory clinic for assessment. So, and with that, it's quite holistic as well. So you might have your psychology, your nursing, your physio, your occupational therapy. Often you'll have dietitian as well. I guess that's depending on the need and the severity, because as people
to make sure they eat.
Yeah, people with dementia, as they get older, often their intake is reduced or their appetite can be reduced as well. So it's all about making sure they're getting the right nutrients
Yeah.
to sustain what they're doing.
Yeah. They forget that their breakfast is there and then it sits there for ages and it gets moldy.
Yeah.
And
Oh,
oh, poor thing. It's true.
that's true.
It's true. The next one we might cover is so upper limb. So I didn't know that because us physios we do learn how to work on shoulders, elbows, hand, upper limbs, but then OT does upper limb as well. So can you
Yep.
tell us what you and physios do differently, or how we work together in
Yeah.
situations like these?
Yeah. So I guess my biggest encounter with upper limb therapy has been like around stroke rehab. So where someone has had some weakness in one of their arms. So I guess OTs and physios work together. OTs and physios both cover the shoulders. And I found every time I've gone to see one of my stroke clients, the physio's always beaten me to it and come up with a great plan for the upper limb, a great plan for the shoulder. And then they sort of leave the shoulder down for us. So often I'll link in with the physio and we'll work on the shoulder together. So that way it's getting double the amount. So when you are doing some upper limb therapy, we always need to make sure that that shoulder is stable and is functioning appropriately before you start using everything else. So if your shoulder's not in a good position or it's, sublux, which is where it's sort of hanging down and you get that heaviness. And if we're using it in that position, sometimes it doesn't lead to a great outcome. So you really need to make sure that you've got good outcome here and good progression here before you start using your hand. So we'll often take a lot of work up here. We might do some fine motor stuff, but it won't be that reaching and grasping until we've got good control of our shoulder. So we work together really, really well, and it sort of complements. So I guess physios with the shoulder focusing on that reaching and that range of movement, and then we're sort of focusing more below that on, I guess, the movement to enable us to do what we need to do.
Yeah, because I always do the general stuff, which is being able to put the shirt on so they need to reach up high or grab a cup or something. But I leave you guys to do like writing or eating or picking up a pen or putting a needle and a thread together, those sort of things. I'm like, that's too much time and effort for me, so I just refer.
I think because it's more functional as well, so it's very, very task focused or occupation focused. It's sort of it sticks with us usually. So I think when it comes to that stroke rehab, there's obviously some other deficits for the person as well, like with their walking. So I think typically physio will tend to focus on someone's walking and mobility and I guess their balance. Well, they'll also consider the shoulder, and then with occupational therapy, we're more considering the function and how we can, bring everything, somewhat back and just work on improving it to get them to use their arm in a functional way.
Yeah, because it's like usually your therapy sessions are an hour, and there's only so much you can do. And like with the physios, you want them to do it regularly, often the same thing over and over again, but you can't do everything. That will take you 3 hours if you were to do everything. So we always split up the tasks, don't we? All right, amazing. Anyway, so the last thing we would maybe touch on is your love of end-of-life care. So oncology and palliative patients. So how can occupational therapists help with that?
So I guess it's about maintaining a good quality of life and helping people to, re-engage in the tasks that they're wanting to be able to achieve. I guess at end of life, some things are not as important to some people. So while working with older people that aren't at end of life, we might be identifying needs around wanting to be independent with meal preparation, wanting to be independent to vacuum their home. That's often less important. So with end of life, often it's around access to the home and making sure that we have appropriate, or the client, has appropriate equipment set up for them and that they're as safe as possible. And it might also be around providing a wheelchair to get out and about into the community because they can no longer walk. Engaging in little memory boxes as well. So bringing out that sort of creativity side and making some create some memory boxes, for the family for when they pass. Also,
That's nice.
with some conditions, yeah, it is lovely. With some conditions for end of life care, some people can get quite breathless as well. So I guess it's about providing that education on how to manage that breathlessness, looking at conserving or saving our energy, and pacing ourselves when we are still doing tasks, because often people will have good days and bad days, and we often hear that a lot as we get older. I had a great day yesterday, so I did everything, or I didn't have a good day, I just stayed in bed. But when we are having those good days, it's really important to make sure that we're not overloading ourselves and we're still pacing ourselves so that we can continue to do the tasks that we want to do. So it's around providing a lot of education and a lot of support. And it all sort of ties in together quite nicely as well. And we work quite closely with the GP, with the physician, with the social worker. Sometimes they may have physio involved depending on where they're at and what they want to achieve. Often having a dietitian as well, just to make sure that they're getting adequate intake, or if they do have reduced appetite or aren't eating as much, just making sure that the nutrients are there. But it's all dependent on that person and their plan and what their expectations are around that end of life management.
Yeah, that's great. Because there's a lot of patients I've worked with who are, palliative, and majority of them want to go home. They want to they want to see their families for the last time, especially when COVID is happening and was happening, really intense. They couldn't, so families couldn't come into the hospital to see them. So they really wanted to go home so that people could go and visit them at home. But they couldn't because, there weren't rails, or they need a wheelchair, and all occupational therapists need to do is prepare everything. And normally there are funding for patients who are at end of life that can help hire equipment, and then you can suss it out, and then they can pretty much go home within a day or two and then die happily and peacefully, surrounded by loved ones at home. So amazing. Yeah, beautiful.
Really good.
Okay. Well, I pretty much have covered all the questions I wanted to ask about occupational therapists, and you've beautifully covered it all. Is there anything else you would like to share with our audiences? That the most common questions you've been asked, or myths that you want to,
Okay. So the first one, we are basket weavers. I mentioned that earlier. I have never woven a basket in my life. So that's probably the first myth that comes with occupational therapy. The second biggest thing, I used to get it a lot when I first started working, was occupational therapy. So you're going to get me back into work. I'm 80 years old. I don't want to work. And I'm like, no. Like that's because occupation is usually associated with jobs. So I guess in the context of occupational therapy, occupations are our tasks that we do every day.
They probably will rename that, wouldn't they? Because like you said, basket weavers, wasn't it, it originated because someone wanted to do therapy, and back in the day, basket weaving was a common thing to do to help with fine motor movements with their hands.
Yeah, exactly. Exactly. I think the only other thing I want to bring up is, if you or one of your family members is experiencing any sort of change that's out of the usual, that might be impacting on their safety at home, impacting on their independence, or you're concerned that they might not be able to manage at home, sometimes it is often a good idea to get, I guess, specialist opinions. So even if that's going to the GP to access referrals, whether that be for occupational therapy or for physiotherapy to help with falls prevention as well, those sorts of referrals can be really good. So that way we can support the person to achieve what they want to achieve. And quite often our referrals come through and it says, Mrs. Smith wants to remain at home, but family has concerns about her memory and her thinking. She's falling every second day, and they're just not managing, and they would like her to go into aged care, but she doesn't want that. So that is, in community, that's often a lot of our referrals. So we can always come out and do an assessment, see how someone's going in their own environment, looking at adding different supports, whether that be equipment, just providing some education around strategies to help manage with daily tasks, or even looking at increasing services and providing referrals so that someone can access NDIS or access a home care package. Yeah, access respite if they're needing a bit of a break as well. Yeah.
Beautiful. Okay, that's really helpful, Bree. Thank you so much for agreeing to doing this interview with me. Hopefully, we can create a lot more awareness on how we can help. Because the last thing we want is someone to come in and I'm like, oh, you could just do this easily, and they're like, oh my god, I could have done this for 20 years and I didn't know. That's what we want to avoid, don't we? So yeah, thank you again. So Bree Edwards doesn't have she's not on social media, she's a hippie. But if anyone would like to ask Bree a question or any occupational therapy related questions, please message Fitness Actually or email us. That way we could always form a list of questions, and then we can do part 2 interview with Bree, and she'll be happy to share her information with us.
Of course. Thanks,
Thanks,
Shu-Mei.
Bree. Thanks.
Have a great day. Bye.
Bye.